Good evening, everyone. A warm welcome to all dignitaries, MMC Observer, Dr. Sachin Gaikwad, expert teachers, presenters, both team participants, Team MAHAIP members, Team MAHAIP Case Challenge coordinators, all MAHAIP members and PG students. Today, we are in fourth episode of interesting session MAHAIP Case Challenge, which has become so popular in short span of 1 month that previous all episodes were attended by more than 1,000 delegates. Today, we have guest of honor Dr. Yogesh Parikh sir, who is National Vice President, West Zone IIP. Then experts are Teacher of Teachers, Dr. Suhas Prabhu sir, and Senior PG Guide and Professor of Pediatrics from Bengaluru, Dr. N.K. Subramaniam sir. Dr. S. Srinivasan sir has also joined from USA, especially for this episode. Today we have two presenters, one from Navi Mumbai IIP, Treasurer of Navi Mumbai IIP, Dr. Amit Saxena sir, and second one is from Wardha, Dr. Dinesh Hinge. And the two challenger teams are, first is a mixed team of Nasik IIP plus Malegaon IIP, and second one is from Palghar IIP. Today's moderators are Dr. Deepa Firke ma'am, who is Professor of Pediatrics in Miraj Medical College, and also she is past executive body member of Maharashtra IIP. And second is Dr. Neha Singh, who is from Raigad IIP, and she is also co-chairperson of Maharashtra IIP Women Committee. So friends, now we'll be heading to this interesting session, and I request Dr. Neha Singh to proceed further. Over to you, Neha.
Thank you, Amol sir. Good evening to all the respected dignitaries, seniors, and my dear friends. Welcome to you all to the fourth episode of Maha Case Challenge Season 2. I, Dr. Neha Singh, co-chairperson of MAHAIP Women's Committee and practicing pediatrician from Navi Mumbai Raigad district, as well as my partner, Dr. Deepa Firke ma'am from Miraj, is moderator for today's case challenge. Now I request our MAHAIP president as well as IIP executive board member, Dr. Ramakant Patil sir, to please give his views for today's session. Over to you, sir.
Thank you, Neha. And it is rightly and aptly started with the flyer that what about challenges. We pediatrician and medicos for that extent daily face the challenges, and these challenges are inevitable, but being defeated is optional. So we will have challenges, and greater the challenge, greater is the gratification and glory in overcoming it. So we have got a revered clinician, Dr. Suhas Prabhu sir, for an expert today, and also our friend, pulmonologist, National President of Pulmonology Chapter, ex-president, last year's president, Dr. Subbu, we fondly call him, but Professor Dr. N.K. Subramaniam, and our colleague, friend, and mentor, Dr. Yogesh Parikh sir, has graciously accepted to be guest of honor today. Friends, this is really a challenging, but at the same time, I will request all other audience and co-host to keep mum unless experts like Professor and Subbu wants to intervene or ask something. But even presenters, Dr. Amit Saxena and Dr. Dinesh Hinge, they are going to present their case. But see to it that we will finish it in 45 minutes, including experts' comments. And I welcome and really congratulate the today's teams of Nashik IIP led by Dr. Prasanna Parashar, Piyush and Jitendra Gandhi, and Nashik Palghar team by Dr. Amit Sawant, Amay Deshpande and Prafulla Rane. And we are all ears and we are all interested in how the cases are being decoded. So let us be on track, let us be on time, and we will not divert, including presenters and even the decoders. And rest of us stop suggesting on chat box and even talking during this thing. Everybody will get a chance to have their queries and comments at the end. With this, I again congratulate Dr. Pramod Kulkarni sir for taking these episodes twice a month case challenge, and aptly supported by Dr. Neha, Dr. Anjali Gokarna and Dr. Deepa Firke. So over to you, Deepa, with welcoming all the dignitaries, presenters, delegates, and today's teams decoding the cases. Over to you, Neha.
Thank you, President sir. Now I request Dr. Pramod Kulkarni sir, the coordinator of MAHAIP Case Challenge, to please give his views on this today's session.
Good
Over-
evening, everybody, and welcome to this unique session, let me say. We are very fortunate to have the experts, Dr. Prabhu sir and Dr. Subramanyam sir, and the guest of honor, our VP West Zone, Dr. Yogesh Parekh, and two fantastic cases, to new presenters, and two new teams. Let's not waste any moment and indulge into the
Our sir to please introduce our guest of honor, Dr. Yogesh Parekh sir.
Thank you, Neha. Dr. Yogesh Parekh sir is a former professor and head of pediatric department at Government Medical College Rajkot. Presently, he is working as a professor of pediatric in Surat Medical College. Then he was president of Academy of Pediatrics, Gujarat State in 2021. He was executive member for 4 times in 16, 17, 18, 21. He was a national convener of IAP NRP program in 2021. He was the national coordinator of NCECD in 2000, from 2021 to 2023. He is also a national advisory board member of IGP in 2020. He was executive board member of Central NNF in 2019. He was vice chairman of Family Benefit Society for 2 terms. Then also he is executive board member of Environment and Child Health Group of IAP. So welcome Dr. Yogesh Parekh sir, today's guest of honor.
Thank you, Dr. Amol sir. Where you have got all the information? I have not sent your CV to you.
It is feed in my mind.
Okay.
Everybody knows Yogesh Bhai and his achievements.
Yeah. Thank you, sir. Thank you. First of all, thank you very much, MAHAIP, for inviting me as a guest of honor, and congratulations for this new challenges like this MAHAIP arranging the MAHAIP case challenge with the 2 new experts, 2 new teams, and 2 interested cases. So and I have names. Thank you very much, Dr. Amol Pawar and Dr. Ramakant Patil sir, President MAHAIP, and the Secretary Dr. Mohan Varke with me today since last 4 days. Treasurer here with me at Gandhinagar with for the IMNCA training supported by WHO and UNICEF. So he's waiting for the dinner downstairs. And thank you very much for inviting me. As Dr. Amol informed me for these 2 teams, team Nasik and Malegaon, and team Palghar IAP. So I have prepared 2 cheats for this both the teams. Should I show that cheats, and I will put in the one box, and then we can make a draw?
Yes, sir. You please keep it in a bowl and please pick one chit. Choose one chit.
I don't have bowl, Dr. Neha, but I have kept this coffee mug here from the restaurants. Okay. So should we proceed like this, or anything, any protocol, miss?
No, sir. You
Oh,
can.
Yogesh sir, what you can do, you have to tell first case which team will face Dr. Amit Saxena.
Okay. So we have 2 experts and 2 presenters, Dr. Amit Saxena and Dr. Dinesh Inge.
Yes, sir.
Yeah, okay. So this is the one cheat for the team Nasik and the Malegaon, and the second one is for the team Palghar. So
Yes.
I am putting both in the one this glass. Now I am shaking this both. Then this team Palghar IAP is the first one.
Okay. Thank you, sir. Congratulations, Team Palgar. You are the first case challenger, and you will be facing Dr. Amit Saxena.
Neha, just a minute. I would like to interrupt.
Okay.
So wherever the teams or the presenter face the problems of not getting connected or unstable internet, in that case, my humble request and appeal to them, put off their video. So
Yeah,
in that case, the connection will work properly. So everybody will be able to hear. If there is complaint from the organizers or Neha or the team, that just put up your video. So everybody will be able to hear you properly. Thank you.
Today we have dynamic personalities as an experts, and the two dynamic personalities are Dr. Subhash Prabhu sir and Dr. Subramaniam sir. Dr. Subhash Prabhu sir is consultant pediatrician at Hinduja Hospital, Mumbai, ex-honorable pediatrician and HOD Pediatric Department, KB Baba Hospital, Mumbai. He is member of IAP COL 2011-2012, convener revised PSPID RAP board modules, co-author of GEM on childhood TB, EPID, MS, antibiotic section editor of Sir is author of over 50 publications, chapters in co-editor of textbooks, Rational Antibiotic Practices, Evidence-Based Practices in PID, chairperson of Government of Maharashtra Task Force for Tackling Third Wave of COVID in Children. Sir has been recipient of 9 variations. Welcome, Dr. Subhash Prabhu, sir. Our second expert is Dr. Subramaniam, sir. Sir is Professor of Pediatrics, Chairperson IAP National Respiratory Chapter, past Secretary National Respiratory Chapter, EB member of 2000, EB member at 2012-2020, various posts in IAP faculties in modules, CME and conferences, orations, award, books and publications. Sir has special interest in pulmonology. Now I request Dr. Subhash Prabhu sir to please give his blessings.
Oh, thank you. Thank you, Amol and Patil and Pramod, of course, for inviting me to be the expert for today. And I understand that we have to decide at the end how the teams actually approach the case. And of course, there are two things I want to say. One is the fact that in every case, the approach, really speaking, is more important than the final solution. We all understand that everybody, including me, occasionally has a case where you don't find a solution. What is important is the rationality of the approach and the methodology of how it is done, starting from the symptoms, the signs, and the investigation. So that is what I will be saying, and I will be commenting on that at the end. The second thing I want to mention is it's not just the fact that you reach the diagnosis, but the fact that you reach a conclusion in the shortest possible route or with the minimum effort and investigation. That speaks for the clarity of your thought. There is a saying that the better doctor is one who makes a clinical diagnosis and then has investigations to support or confirm what he said, rather than somebody who just does a lot of tests and then tries to say, oh, this test is positive, so this is the diagnosis. So these are my two comments. So I will be assessing the teams on these two things. Thank you.
Rightly said, sir. Thank you, sir. Now I request Dr. Subramaniam, sir, to please give his lesson.
I think I'll reserve my time more for the comments than for, giving the, comments now. And since I second all the words of Dr. Subhash Prabhu, I don't want to repeat the same. And wishing them all the best. May the best team win, and the team that loses will win again in the next sessions to come. Thank you. And I should not forget my dear friend Dr. Anmol for me, for inviting me for this occasion, and all the team and everybody in MAHAIAP, which is in fact my IAP, because I studied in Maharashtra. Therefore, I owe a lot, and there's no way that I can refuse any invitation. Yogesh Bhai and Suhas, thank you very much for being with us in this occasion, and we'll go ahead with the presentation.
Thank you, Subramaniam, sir. Now our first presenter is Dr. Amit Saxena. He has done MBBS from SAIT, GSMC and KEM Parel Hospital, MD from Sion Mumbai, Professor in Pediatrics at DY Patil Medical College, Nerul, Navi Mumbai, in charge of Pediatric Hematology Subspecialty at DY Patil, Treasurer of IIP Navi Mumbai, and he has publications in national and international journals. Sir, you can start sharing your presentation. He will be giving challenge to team Palghar IIP, and the team members are Dr. Amit Samant, Dr. Ameya Deshpande, and Dr. Praful Rani.
Thank you so much for the opportunity to present in front of the stalwarts and experts. So I'll start sharing my screen.
Yes, sir. I will request everyone to please don't unmute in between and don't give your comments in the chat box.
Is this fine?
Yes, sir. You can proceed.
Okay. So all the best to Team Palghar. My case is a recent one. It was a 10-year-old female child born of a third-degree consanguineous marriage, living and residing at Koparkhairne, Navi Mumbai, Hindu by religion. And she got admitted with us with the complaints of swelling around the eyes and face for the last 5 days, noticed since last 5 days, and also complaining of reduced urine output for the last 3 days. So would you like to comment, make any comments on this slide?
So background of the edema, which is starting from the craniofacial, which is starting from the face forward. So we have to think of the etiology pertaining to the renal system.
And most commonest we see is nephrotic.
And also we have reduced renal output also. So that also points something towards the renal etiology. Anything else which you find significant over here?
Apart from that, would like to get some another complaints in that.
The color of the urine.
Color of urine and.
Yeah. So we'll go ahead with that. So I'll just proceed with the case and asking inquiry about the chief complaints. There was swelling around the eyes noticed since last 5 days, which aggravated in the morning and relieved over the course of the day as per the mother. It was associated also along with some abdominal distension, but after admission in the hospital, we did not notice any diurnal variation. And also there was history of reduced urine output that we already said. So with this history, would you like to ask any further questions? What questions would you like to know from me?
I'd like to ask whether she was taking any medications prior to this history, any supplements or any non-specific fever medicines, like she had a non-specific fever for a day or two previously, and any medications for that.
So basically, what are you thinking for, which medications are you thinking about?
Usually NSAIDs like ibuprofen and all, they tend to present like that, causing nephritis, and they can present like this.
All right. Anything, any other questions that you would like to know?
Associated
though it is suggestive of renal involvement, we also have to rule out other systems also actually. The most common is cardiovascular system also. So because she's saying that it is more in the morning and less in the evening, though there is no diurnal variation which is noted in after admission, still I would like to ask whether any if she has any breathlessness or whether she is having dyspnea on exertion or some cardiac symptoms, which is one thing. And the second thing that I would like to ask is that the abdominal distension is going on increasing abdominal distension, and whether the swelling is also increasing, and whether she is having swelling at other parts of the body also, like limbs also, like she has anasarca or something.
Perfect. So she did have swelling all over the body. Any other system questions you would like to ask? So you asked
I'd like
about,
to ask whether any previous rashes would like to know whether previously any rashes or anything, any recent, any pyoderma or anything she had.
So I'll go ahead with the questions that we asked them. And there was no history of any hematuria, dysuria, pyuria, urgency, or frequency of urine for the renal complaints. As rightly said, there was no history of for cardiac. We asked for breathlessness or exertion, recurrent LRTS, chest pain, palpitation, or syncope. We also asked about hepatic symptoms, so jaundice or lump in abdomen notice, which was not seen by the parents. We also asked about any pain abdomen, loose stools, constipation, or vomiting. There was no history of noticing pallor by the parents, but history of fatigability was present. And also there was no history of any worms noticed in the stool by the parents. There was no history of headache, convulsions, no history of any known allergy, and no history of any coxswain cough contact. So after all this negative history, what impression do we have of this case till now?
It is less likely to be a cardiac system involvement. Anatomically, less likely to be one hepatic involvement or any metabolic disease. More likely, we are again
involvement. Yes.
at a child with the renal problem. So
Yes.
we have to focus mainly on the renal. Of course, we have to keep other systems also in mind while investigating and while examining the child.
Correct. So even we thought that it is predominantly renal. After that, differentials at this stage, as you rightly said, most commonly it is renal, looking like renal. That is nephrotic or glomerulonephritic of picture to be decided. But other causes were less likely, correctly said. Coming to the past history, which was significant and gave some twist to the story. The patient had similar complaints at the age of 3, 5, and 7 years of age. So again, when a child has complaints of edema, anasarca kind of, and now there's also similar complaints at 3, 5, and 7 years of age. What things will come to your mind? What can be the recurrent causes of edema in this case?
Again, as I said, recurrent cause can be still a nephrotic probably. First is always a nephrotic because they tend to relapse. Any small infection, it will relapse. Other probabilities which we will have to consider whether it is nutritional, because any associated illness and the nutrition suffers and she presents like that, and maybe that's parents have noticed, and it can vary according to the non-specific illnesses which makes her nutrition to be very poor during that time and she presents. That is one thing which I'll keep in mind. Third thing that comes to mind with this previous history is whether there is any autoimmune system which is involved, like whether it is any autoimmune illness which is presenting like that.
Mm-hmm. Okay. So we also thought it is looking more like a nephrotic or a renal involvement because recurrent episodes are there. But as you rightly said, the other differentials that we should definitely keep at the back of mind. Just mind it that this patient was taking treatment, but he had lost all his records. So we do not have any records of what he has taken, what he has not taken. So, and only we had to rely on the history. So this is the history that she came up with. They had received actually blood transfusions for this every episode of edema in view of severely low hemoglobin. And according to the mother, the edema used to resolve after the transfusion. And she was after that on mostly iron supplements according to the mother. And there was no history or evidence of the patient receiving steroids. The patient also complained that whenever the iron supplements were stopped, the symptoms recurred. So with this twist in the story, would you like to alter your diagnosis or try to think about something else now?
Yeah, so primarily this seems to be a hematological issue, right? With this history of getting a transfusion and then taking on and off iron supplements and never receiving steroids. So probability of nephrotic is now much down. And the first thing that comes to mind is obviously there is some hematological involvement which is there. And
abdominal distension.
Then I'll go for the other examinations. Once I do a physical examination, then I'll be more sure about it.
Okay.
And
in addition to the hematological problem, we have to keep in mind the protein-losing enteropathies or something like that.
All right.
The child is having those kind of problems because they are also present with quite low hemoglobin quite often.
Okay. So, what questions you would like to ask here further?
Whether any familial history of other kids receiving blood transfusions is what I'll try to ask, because this seems to be sometimes familial. Other is obviously the diet related, like Dr. Amit said, whether any signs of frequent diarrheas are there, or whether poor weight gain, and these episodes have been intermittent. So related to her diet, we'll ask queries about what is her protein intake, what kind of food she has usually, and from that we can come to some conclusion whether it is related to her GI system.
So great. So we asked the questions, and for hematological questions, we asked whether there was any history of bleeding from any side, or prolonged fever, weight loss, night sweats, recurrent infections, or any significant family history, which was not there. We had one report last time when they had come in February 23. This is 6 months back, to the hospital in Navi Mumbai, another hospital in Navi Mumbai, where they had got some reports were there with them. So electrophoresis was done, which was and CBC report was there. So this is the CBC picture that we have. So at this stage, I would like to just comment on the CBC and electrophoresis. What do you think about it? The hemoglobin is, if you can just comment on this slide.
It's a microcytic hypochromic picture.
Yes.
So with the microcytic hypochromic picture, we have usually the differentiations of the iron deficiency anemias and the thalassemias. If RDW is there, it can further help in distinguishing.
Yeah, it was not there in this slide.
Not there. Yeah. So
here also was not given. So this is the only report. So yes,
but you even think of hereditary spirocytosis or ovalocytosis, because that is also come present as because hemoglobin 4 at the 10 years of age with thalassemia major presenting at 10 years of age is very unlikely, and that also frequently. I mean, at
89.5.
So more likely to be some hematological cause. I mean, it's a hypochromic microcytic anemia. We have to think of that. Can we get a RDW of this child?
Unfortunately, RDW was not available. But I'll tell you that RDW during our admission was on the higher side.
It was on the higher side.
Yeah. Spirocytosis or something.
Yeah.
Spirocytosis, there was no history of jaundice noticed ever. So spirocytosis, I would say, would be less likely. But yes, iron deficiency definitely yes. Thalassemia major, again, the electrophoresis report we have in front of us. So again, that was ruled out.
Yeah.
Okay. Going ahead, other investigations also we have. So we had a liver function test. Sorry.
So that last slide, what were the platelets and all? It was involving only one cell
other
line.
cell lines were normal. Total counts you see, yeah, 8,000 platelets were 250, and neutrophil differential also was pretty okay.
Yeah.
The other investigations that were there was that the liver function test actually showed low total protein, and albumin was significantly low. Rest of the findings were normal analytically. The enzymes and the bilirubin levels were normal. The urine routine report came to be normal, and the albumin fat ratio also came normal, as we had expected because he had received transfusions. But this time the report was there and it came normal.
Okay.
USG abdomen was done, which showed pseudo thickening of gallbladder and mild ascites. So in this case, at that point of time, they did not transfuse, but he was started on iron. According to mother, the child became better and was discharged without needing a transfusion. So what are your thoughts on this case now that he is getting better with iron?
Sir, before going to the investigations, can we go back a little and I mean, can we have some insight about child's growth? Because now child is having sickness since 5 years till 10 years of age, with multiple transfusions required.
This was all the this was the previous report, so I have just kept it here, and this is the history that after iron the patient got better. But since you want to know the growth, the anthropometer will be coming shortly, and the child was slightly short for his. She was short. She was stunted.
Okay. Because now even the hematological cause looks like little on the lower side, because the HB electrophoresis is not that bad. That child is having some sickle cell anemia or something like that, or even that spirocytosis and all should have been picked up on the peripheral smear, which any good pathologist would have picked up. So we have to think of something else apart from now renal is out. Now the hematological is little less likely. So we have to think of some metabolic diseases. I mean, the most common disease that we see with the, you are saying that little short child with the recurrent low hemoglobin with what do you say, requirement of more iron and blood transfusions and puffiness of the face and abdominal distension. I think we have to think of, we have to get a thyroid test done because could be a one of the maybe the presenting feature of hyperthyroidism.
Okay. So yes, what you're saying is on the it can be a possibility, but what is happening is that the child is getting better with iron therapy.
And
Better after starting iron.
okay.
Sorry.
So I think I'll stay for the further reports or
Okay.
physical examination.
All right.
And,
So again, she
whatever
presented to us. I'll go ahead. She presented to us when the iron was again withheld for 10 days. She actually finished her iron bottles and then did not buy it again and was stopped for 10 days. And she presented again with the same complaints. Coming to the past, family history, there was no similar complaints. It was a normal delivery. Episode of neonatal hyperbilirubinemia was there, requiring phototherapy, but apart from that, never getting jaundice again. Diet history, it was a mixed diet. Calories, you can see only 20 calories deficit. Proteins also intake was fairly good enough, developmentally normal and belonging to a upper lower class of according to Kupuswamy scale. So this was, I think, this is the complete history that we have. So at the end of this history, what provisional diagnosis would you like to make as at this point of time? Then we'll quickly go ahead with the
At this
examination.
point of time, I think, yeah, and efficiency anemia is what
And
still will
right.
keep as first thing, nutrition. Yeah, and the second thing, as Dr. Amit had said, probably a protein losing enteropathy or something, because they do have anemias frequently. And these are first two things. Obviously hypothyroidism, if at all.
Okay, good.
With the growth normal, now again the hypothyroidism is little. We have to keep it at the last.
Last, yeah.
So again, anemia was significant, and in fact, it was. If you remember in the history, there was a history of particularity also there, and on examination also we found some factors suggestive of CCF. So these are the two things that we kept in mind, and let's go on to the examination part. So the child was conscious, oriented at time, place, and person, moderately built. Temperature was afebrile. Heart rate was 120 per minute. She's a 10-year-old girl. Heart rate was 120 per minute. Respiratory rate was 30 per minute. Blood pressure was 104 by 62 millimeters of mercury. Pulses were felt, and the CRTs were normal. Saturations were normal. So from this vital parameter examination, what conclusions would you like to draw here?
Yes, tachycardia, which is
Looks like a hyperdynamic circulation, no doubt.
Yeah.
Yes.
Yeah.
So tachycardia is there, and the hyperdynamic circulation seems to be correct.
Even the respiratory rate seems a little higher for a 10-year-old child.
For a 10-year-old child, is slightly on the higher side. Correct. Absolutely right. This is the anthropometry that we observed. So height was 125 for an expected of 138, less than the third centile, and weight was 27 kilos for an expected of 32 kilos. Weight seemed to be between the 10th to 25th percentile. So how do you like to interpret his height and weight here?
Yeah, she is underweight.
Sorry?
And undergrown. It seems to be a long-standing malnourishment. Looks like that.
Yeah.
Stunted.
Because
Stunted as well as underweight. Both.
Another point about the weight, any specific thing that you would like to see here? Say about the weight.
Sorry?
Anything specific you would like to mention about the weight here? This child was edematous. She has presented with edema. This weight might be falsely elevated. Yes, more than normal. So on general examination, we found that the pallor was present. Edema was present in nature, and it was present all over the body. Even over the shins, was pitting edema. There's no jaundice, clinosis, clubbing, or lymph nodes. There's no signs of any bleeding like petechiae. Hemolytic facies was not there. And no cold or clammy extremities were noted. Anything else you would like to know in the general examination, or would you specifically look for while doing a general examination of this child?
Was a clubbing there?
Clubbing is not there.
Clubbing is not there.
Okay.
Till now, we are dealing with the patient. Yeah.
With the eye exam was normal. There was no KF ring or nothing.
So no, there was on general examination, naked eye examination, no obvious KF ring. but of course, we did not
I
do a
try to see
strict
whether any signs of vitamin D deficiency there, rachitic rosary or any fraying of bones. Anything.
correct.
I'll try to see
So
for that.
yeah, so they were not there actually. There was no evidence of rickets or in fact any other vitamin deficiency obviously seen noted in this child. Since we have one deficiency, we could always look for them, but they were not seen. Right. Great. Going ahead with the system examination, we noted that there was a generalized distension present. Flank fullness was there. The veins were not prominent. Umbilical and hernial orifice is normal. Hepatomegaly it was tender, and just palpable spleen was also noted. And shifting dullness was present, suggesting that ascites is there. So, what would you like to comment on this these findings?
Tender hepatomegaly indicates that there is some amount of hepatomegaly, obviously, and since it's tender, it has to be a congestive type of hepatomegaly. So, are we seeing some sort of a liver issue which is causing a little maybe?
Or we can get in, she has tachycardia, severe anemia. So we can also expect that the patient may be having
yeah, so probably whether these are all signs of because of CCF she has this tender hepatomegaly or something.
Correct.
And because of that same reason, there is mild ascites with a shifting dullness which is there.
So what else would you like to know in other system examinations, or what would you expect to be there in the presence of in the other system examinations? What else? What all findings can you expect to be there?
So if I try to check accordingly, CVS will try to see whether any murmurs are there, whether any gallop rhythm can be heard. To find out whether there is any other kind of are there, whether any raised jugular venous pressure is there. So
okay,
try to check for that.
Yes, so we did check for that, but we did not find any other abnormality which was present. So other systems were CVS and RS. There was no basal creps, and CNS wise she was fine. JVP was slightly raised. So now here, this finished our examination, and at the end of this history and examination, the main issues that we were facing were the child has severe anemia and in CCF, and she has generalized edema with history of hypoalbuminemia present. So the question that came to us was that how do we explain both these things together? So what are your thoughts on this?
If we have to club them together, saying that there is anemia and that is causing CCF and with generalized edema because of hypoalbuminemia, both the things come to a common picture where like it is nutritional in nature, which is causing that. So either our absorption is affected. So maybe are we facing some sort of an enteropathy which is causing both?
Very nice, very nice. We are looking more in terms of enteropathy.
Yep.
Very nice. Okay. So how do you like to proceed with the investigations in this child?
Nice.
What all investigations would you like to do in this case?
So, are there any signs of malabsorption? What are these stool routine examinations? Are there food particle since in the stool? That will give some clue towards the chronic malabsorption which is going on. And
so you can do a certain type of investigation, like for a stool routine, then we'll try to do TTG IgE, with IgA, sorry, TTG IgA, with stool calprotectin. These are some tests which we'll like to do to see whether there is any enteropathy there.
All right. So we obviously first we went ahead with the basic tests that we had. So CBC picture that we wanted to look. So here again similar kind of picture, microcytic hypochromic anemia. And here you are asking for RW, so RW was quite wide. The cell lines were still maintained. This was a peripheral smear picture, and retic count we also did. So it was 2%. The corrected retic count being 1%.
No active.
So no hemolytic anemia. It's more likely to be iron deficiency anemia.
Right, right. So in hemolytic, you would have expected the retic to be on the higher side, but here the retic count is still on the lower side for the degree of anemia. Okay. This is the LFT. Again, more or less similar picture that we had found 6 months back. Severely low albumin, but enzymes and bilirubin levels are normal. We also did a urine routine again because it was the first test that we did for residents at SEND, and this again was normal. RFT was done, which was normal. Lipid profile was normal. ESR was 44, and we had spent a sputum for gene expert test also. That also came to be negative. Any comment on this ESR of 44?
It signifies any anemic patient can have a high ESR.
We should have corrected ESR actually, but
Yeah.
because hemoglobin 6.2 ESR 44 is quite expected.
All right. Any correlation with CCF part as well?
Yes.
In CCF, if the CCF is quite severe, we do expect the ESR to fall as well. But here the ESR is still on the higher side. And we went ahead with the iron studies to confirm the diagnosis. The iron was, you can see the report, the iron levels were quite low. Ferritin was 28.8. UIBC and TIBC also were not, the classical iron deficiency picture that we get, it was not found in this child. Any explanation for this that you can provide? Why we must have got this kind of report?
The albumin levels are very low.
Yes.
That can also cause fluctuation in the UIBC and TIBC changes. Plus iron malabsorption can also lead to.
This is possibly the iron malabsorption at the GI level. So that is why the TIBC is not.
Other probabilities at UIBC, TIBC, they are they are attached to a protein. So if it's a protein deficiency, protein
hypoalbuminemia can
you might have
cause.
UIBIPS, you might have a low UIBS and TIBS. It's a normal thing. You could have otherwise had lower.
Another thing that we have to remember that the child was taking some amount of iron supplements and he had stopped recently only. So maybe that might also be the reason why you're not getting the classical picture.
Yes.
When B12 came very low, very high. So most likely he must have been taking some supplements. Coming to the stool routine as rightly asked, this was the stool routine that came to us, the most quite important one. Occult blood, we did it for 3 consecutive days. It was every time it showed occult blood positive, but there were no OVA or any parasite scenes. Fat globules were negative. So what inference do you draw from all these basic reports that we have?
Still, we stick to like primarily this thing that there is some sort of nutritional reason to this protein iron deficiency as well as protein deficiency, both seen together.
Yeah, and you were mentioning about a losing causes, right?
Yeah, protein losing enteropathy.
Yeah. So amongst the protein losing enteropathies, what are the commonest things that you would like to rule out? You mentioned about some of those. So I think you all mentioned celiac disease already. So we also did the test for the same. Okay, where did it go? So celiac disease workup was negative. We did the test and celiac disease workup was negative. During the course of admission, the child was in failure, hence we was transfused. So one interesting fact that came to our understanding was when the mother said the patient has become normal, the child had not become completely normal. The pedal edema was still persisting. So the edema always used to be there. So what conclusion we drew from this was that when after iron therapy, the child was not getting completely normal, but partially normal. But according to the mother, it is normal. So nephrotic syndrome was ruled out. So other cause of hypoalbuminemia needed to be ruled out, as we have rightly discussed, the protein losing part, liver disease, or the nutritional ones. So amongst the common ones, I think celiac disease was one of the most commonest, and we did the test, it was negative. Okay. Any other causes of protein losing enteropathy which you can think of, which could have been possible in our patient?
So considering the history with that pedal edema, in spite of transfusing this child had a tender hepatomegaly with ascites. You can consider some sort of a liver issue, which is there, because with that enlarged liver, maybe because of that, the pedal edema was not settling because of venous congestion. That is one thought which comes to mind. Even the same venous congestion can cause ascites as well. So whether liver is involved, and liver is the reason of the whole problem, because enteropathy, like protein hypoalbuminemia, can be seen because of liver malfunction itself, and even anemia can be because of the same reason.
All right. We had done a USG abdomen, and the liver function was okay apart from the albumin levels, and USG also was not commendable about the liver pathology as such. Any other things that you can think of?
For the child on anti-helminthiasis, was he given?
So we don't know about the past history, but we did give. And he was started on empirical anti-helminthics.
Right.
And he gave a history of passing worms on the stools on day 3. And it
So
looked
that can
like
be cause of the non-erosive or non-ulcerative GI, non-losing, protein-losing enteropathy also.
Okay.
The parasitic infestations.
All right. All right. How would you like to go ahead with the confirming this diagnosis?
Yes, okay.
Concentrated
something?
stool legs.
Will try to do an endoscopy and see.
Okay.
See the texture of the
Yes, right. So we did a stool routine again just to see whether now the pathology picks it up, but again it came normal. But we did go ahead with the endoscopy, and we did upper and lower GI both.
Both.
And it was suggestive that we have done it recently. Biopsy results are still awaited. But did show that in the dural part there was hookworm infestation. I think you have reached the diagnosis correctly.
Yeah.
Thank you.
Thank you so much.
Thank you.
Thank you. It was an amazing case, sir. Thank you, sir.
Very interesting.
It took us to the roller coaster of different systems.
Yeah, even we were like in a dilemma by going through the case. I think it. I hope the patient recovers and there's nothing else. So
yeah, hopefully.
Yes, sir. Definitely.
But
can I stop sharing now?
Yes, sir.
very surprising not to find anything on the stool routine.
Very true. But endoscopy helped, right? Good.
Thank you, Dr. Amit, for such an interesting case. Now, I would request Dr. Suhas Prabhu sir and Subramania sir to give his expertise comments and how did the team approach and all.
You want me to go first?
Unmute.
Thank you for this really very interesting and unusual case. I confess we haven't really seen this bad hookworm infestation for decades. But that's possibly because we live in Mumbai, where we don't really see children go out in the fields in barefoot. But looking at the case from the beginning, to me, it was pretty obvious that there was some kind of an occult iron loss, because that was very, very clear. And I have a couple of points to say regarding this. One is the fact that I do believe that you should show a picture of the patient. That gives a lot of clue. There was a lot of discussion on hypothyroidism, which could have been clearly avoided if you just see the patient. And unfortunately, that picture was not shown. I know you don't have to identify the patient, but you can mask the patient's eyes or whatever. It would be a good idea to at least, show a picture of the child. So that was one thing. Secondly, nephrotic syndrome didn't really appeal to me from the beginning, considering the fact that the child was 10 years of age. In this case, consanguinity was a red herring. It was there right in the beginning, so that raises your antenna to look for other things, but they were not there. And the other, my point was the fact that there was a fair amount of discussion on the old reports that the patient had brought. And unfortunately, according to me, this discussion happened even before the patient's physical findings were mentioned. And this happens to us all the time. Your patient comes to the OPD and he asks for the main complaint first, and then he throws a big pile of papers at you and says, "Isko dekho, report adi baga." And I think that is a mistake, because that sometimes leads you on the wrong track, number one. And also the fact that it stops the way your training on how to arrive at a diagnosis. As I mentioned right at the beginning, even before this case was presented, it has to be physical, history, physical examination, and then the investigation. When you see the investigation or discuss them first, you often go on the wrong track. So these were my comments on this patient. But yes, the team did narrow down to the fact later that it was an iron loss. And I thought that I didn't really think of hookworm because we don't see that so often. My thought would have been this child has some kind of angiomatous malformation. I've seen a couple of cases like that who come with recurrent anemia requiring transfusion. And unless you do an endoscopy was the answer. And whether it was hookworm or something else, the endoscopy would have given you the answer. I didn't really think of a protein losing enteropathy because the child's growth was not so badly affected. It was more of an anemia rather than their child would have been more severely nutritionally affected if it was a protein losing enteropathy. And most of them do present much earlier than at 10 years of age. So this looked to me like something occult blood loss. And anyway, you arrived at the diagnosis then. So these are my comments.
Dr. Subramanian, sir?
Thank you, sir.
My comments are, I will go in sync with the way they have discussed the case rather than coming to the last point. In the history, the presenters were biased about the renal because they saw that one thing that there is a decreased urine output. Mind you, decreased urine output can happen even in cardiac diseases. Since there is decreased cardiac output, there can be decreased renal flow and therefore reduced urine output. So urine output in no way differentiates a renal disease from cardiac disease. This is little theoretical, but in practice, what we see is that, once the edema starts resolving, they pass more urine. That is one. Second thing they missed was fatigability was present. And yet they told that it is nephrotic or nephritis. How often we see nephrotic syndrome kids or nephritic diseases present with fatigability, and 10-year-old child, some more history could have been asked. Please re-explain fatigability. Is it that the child gets fatigue while playing? Is it that while going by bicycle to the school? Some specific questions were not asked. You cannot say fatigability because the fatigability, is it really exercise related? And what is the severity was not asked by the team. And the swelling of the lower limbs was not at all asked. There was foreignness of face and abdominal swelling that was presented. The negative history was not asked by the participants. The next thing that they missed out was they never asked, because they were biased, they never asked a past history of joint pain, throat pain, skin infections. These were not asked actually. It's a good history to take. What if there was no report and what if we could again miss? The next thing was that, if the child has got in anthropometry short, but weight okay, and taking that, it is edema-free weight, straight away it takes us to celiac disease as growth failure plus iron deficiency as a syndromic presentation. But they were okay, but they never asked the type of pallor. They said pallor is present, but presence of pallor in a 4 grams doesn't mean anything. See, was it that there was pitting of nails, koilonychia was there? These are very, very important. Now, in evaluation of anemia, after giving transfusion, these things take some time, and they could be telltale evidences. What if this patient could have been transfused outside and presented to my clinic? So these signs will be present, which will straight away point to iron deficiency, and this was missed. Now, what is surprising to me is that how can the spleen be palpable in iron deficiency anemia? At least in my years of practice, I have yet to see a spleen palpable in a classical iron deficiency anemia, even with worms. If the spleen is palpable, I think we have not reached the final diagnosis. I beg to differ from the presenter and the professor that we are still missing something. Just because the worms are passed, we cannot end up by telling that, look here, we have got the diagnosis. You see, the biggest history that is given by the mother is often roundworm, not other forms of worms. So we think that there is poly infestation with the worms, and therefore we assume and presume that possibly there were other forms of worms as well, considering the socioeconomic status and a country like ours. What is surprising to me is that so many times blood was transfused, but nobody gave deworming. I mean, at least this child must have 6 to 7 transfusions and not received a bit of albendazole was a real surprise to me. Now, keeping that ESR in mind, not accepting by levels of hemoglobin and a possible spleen, 10-year-old, I would still keep my thought maybe less than 10% towards looking for some immune associated causes. Could be this, maybe how do you know this child won't develop a lupus in future when it goes to the second decade? And what if the child after deworming ends up with the next transfusion? Then we are all fooled again. So I always feel that the diagnosis is always an illusion. I do not know. I'm more a pulmonologist. Therefore, I would like some hematologists to comment. Do you really need to do bone marrows in these cases? Because although we have got a worm, we have a splenomegaly, and peripheral smear is normal. And what if we can do bone marrow? And I do not know. I want some hematologists to comment. Can this be sideroblastic anemia as well? I mean, and considering that the worm passing is incidental, please, I'm begging pardon. While I accept 99% that yes, I'm also happy, worms causing anemia. But what is my comment is that why splenomegaly or why palpable spleen? What if the bone marrow gives something else? What is the follow-up of this patient? And how long the worms could have been there? And these are the questions that even till now I don't have answer. So whenever there is a question, I don't accept any diagnosis as final diagnosis. These were my comments.
I think Dr. Amit should they are addressed to you these questions.
So this about the spleen part. So we used to always say that spleen might be incidentally also palpable in a few of the patients. So we're not very sure about the spleen part. Regarding the diagnosis, as you rightly said, patient is very, he's just been.
Sir, I wanted to just ask you, can this spleen be incidentally palpable? I agree if it is incidentally found in a patient who is not presenting, but a patient who is presenting with hematological problems, do you want to make it incidental, sir, Amit ji?
Sir, in this case, I would not be 100% sure, definitely not. And that's why we did try to work him up for other causes.
So you did the ultrasound, okay? I will take it as examiner's mistake, just palpable spleen. But on ultrasound also it was enlarged?
So no, I don't, no, it was not this. It was not mentioned at least.
Because somebody will feel something and say spleen is palpable, then I will take it as error, provided it, because it has to enlarge 3 times before it becomes palpable.
Okay. But the spleen was enlarged because I had seen that personally.
Fine. That's a mystery. Okay, done. Please, what if you are missing some malignancy or autoimmune disease incidentally thrilled by passing worms?
But sir, that's what I'm saying, that the patient has not recovered completely. So we'll not be like 100% happy unless the patient does not require transfusion. Only then we can confirm and say, okay, this was causing loss of proteins and causing significant anemia, and that was the only reason that we have. Currently,
Sir, you are a hematologist. How often we can repair on, rely on peripheral SMIT findings in a patient who was previously transfused?
These transfusions were 3 years apart, 3 years, 5 years, 7 years, and 10 years. It was a reliable finding, that I would say. And even the electrophoresis was normal times it was done. So it was normal. So hemolytic anemia again becomes less likely. Bone marrow also, over a period of 7 years, he has required transfusion, but only one cell line is getting affected. Again, less chances that the malignancy will be a possibility. Autoimmune, we'll have to wait for the evolution of the disease, because till now she does not have any rashes or joint pains.
No, some question is being asked. I don't think I'm supporting malignancy, please, for heaven's sake. That was not my intention. But autoimmune diseases evolve over time. They don't present immediately. See, that could be in the pipeline in the next 10 years or so, we will never know.
May I say something? Yes, sir. I just want to add, Dr. Subramaniam, I understand your general principles, but I think in this particular case, we would be barking up the wrong tree. This child has a history spanning 6 or 7 years. The first episode was at 3 years of age. There cannot be any malignancy that will go on for 6 years.
Malignancy, no. I said no for malignancy.
Even an autoimmune disease will come with at least some fever in 6 years. And you will not get a hemoglobin of only 4. See, this is a girl. So if at all you're thinking of without any joint involvement,
I agree for everything.
you're thinking of SLE. Now, if in an SLE, you will see definitely more than one cell line affected. Dr. Amit, correct me if I'm wrong. It's very unlikely that an SLE will have a pure anemia of this degree and have no platelet and white cell involvement.
Okay. Anyway, I am not in that field. Dr. Pramod told that in severe iron deficiency you can get palpable spleen, but I'm fine. Anyway, then if it is fine. But what if it is malaria and things like that? Then so this please, my request would be, what if you miss a malarial spleen? I'm sorry, but please have these thoughts and have an open mind. That's all.
Thanks, sir.
So thank you, Dr. Amit Saxena, sir, for coming up with such an interesting case of iron deficiency with hookworm
No,
infestation.
before we leave, can we have Dr. Amit answer that question? Can it be sideroblastic anemia? That's what would you say?
Sideroblastic anemia is quite a rare diagnosis. We don't think of it as a first differential. But of course, to confirm the diagnosis, we'll have to do a bone marrow and Prussian blue staining.
Correct. So that was exactly Dr. Subramanian's point. Would
No,
you
that's
not do a
exactly what
marrow?
I wanted to know. See, in my my institution, at least I will not send this patient without a bone marrow, which is easily doable.
So the patient is there, we'll think about it again, sir.
I agree that sideroblastic anemia is a rare disease, but so also is hookworm infestation spanning 7 years with hemoglobin of 4.
Can I make one comment?
Yes, sir.
I'm an outsider. Am I
Yes.
allowed?
Yes, sir. Yes, sir.
Yeah,
Yes, sir.
because we have been in the era of ankylostomiasis with severe anemia and all, and having episodes of this much of edema and anasarca for 3 times. Why not endoscopy to rule out some polyposis associated with hookworm infestation, etc., which may cause blood loss? Or, of course, we have seen cases of lymphangiectasia being presented, but of course, there was no fat globules, etc., in the stool. But I think it's worth doing an endoscopy by this thing.
Endoscopy was done, sir.
Yeah, what did it show?
Otherwise, it was normal, sir. It was just the worms that were seen. Otherwise, it was clean, sir.
Meckel's diverticulum, associated Meckel's diverticulum has been ruled out. Yeah.
Not mentioned that.
Yeah, we have to do a PET scan to see, because hookworm was such a common infestation during our days. We have never seen presenting for so many years. And once treated, and this thing, as Subramania mentioned, Albendazole would have taken care of it. I'm sure it's being given in the as a Indian national program, deworming. Okay.
Yeah,
So I want Dr. Pramod Kulkarni's comments.
Yeah, Pramod, I agree with all the
Yeah.
comments by Pramod Kulkarni. While I agree on everything that has been discussed, 99%. But what I was discussing was 1%. That should not shadow down the final diagnosis and the attempt that is made. I was just telling to think that if we can keep our mind open.
Good evening.
That's all. Yeah.
May I comment? I have a comment or two.
Sir, good evening. I'm one
Neha?
outsider.
Yes, ma'am. Go ahead.
Datta from Kolkata. Can I
Yeah.
comment something?
Yeah, please go ahead.
Yes, ma'am. Yes.
Actually, I have not heard the whole session. I just joined in the last few minutes. What I gathered, there was a edema, repeated blood transfusion, and microcytic hypochromic anemia without any definitive diagnosis. Am I correct, sir?
Yes, ma'am.
Okay, so we had a few cases like this, and as Sir Srinivasan sir said, endoscopy and all, and the 2 or 3 cases we got the lymphangiectasia. One is the congenital, one in case of tuberculous origin, but 3 cases we had similar episode of presentations, and it was a pulmonary hemosiderosis. Did the child had any lung symptoms? Did you go for the ball and all, and during the attack, or because it is episodic, you won't be getting the local blood in the stool regularly, and there'll be chronic blood loss either in the lung and all, hemosiderin cells and all. If you can show that, that can be one of the diagnostic evaluation. Pulmonary hemosiderosis in case of chronic microcytic hypochromic anemia. Correct.
Lung symptoms were never a significant part of this complaint. Patient never had any lung symptoms like no cough, cold, or cough episodes or diurnal variation of the cough or anything like that.
I mean, you did the X-ray and all, no? You did the X-ray and all.
X-ray was done, normal.
No, I think
we had thought of tuberculosis also as tuberculosis also, because edema is there, nutritional deficiency is there. So we had done X-ray. It was negative.
If all goes well with this treatment and never recurs, that means diagnosis is almost what you said. But
I
if the
think-
child is again going to have this type of episode, then of course we have to reconsider and do some more investigation.
We have to wait and watch for the treatment and whether response to the treatment is good or not.
I'm sorry, I need to interrupt because we need to start with the second case.
Oh, okay.
It's a very
Deepa,
big discussion
just a
going on.
minute. Just a minute.
Yeah.
I will request Dr. Mahesh Moite to have his comment. And before that, I will just like to have comment and have opinion of Prabhu sir also. This is 10 years old child. So Meckel's diverticulum for 10 years. The bleeding is always episodic, very large melena. It is not continuous blood loss. So Meckel's is less likely. As Sarah said that sideroblastic anemia, the closest differential diagnosis hyper IgE or non IgE mediated cow milk protein allergy, which will say iron dependent iron deficiency anemia like picture, who may not have respiratory symptoms, but patient definitely has got interstitial respiratory signs in this common this thing cow milk protein allergy, and they present as, and I had similar 2 cases, and with complete restriction of cow milk, they didn't come again in 2 years for the blood transfusion or even iron therapy, which was stopped. So these 2 cases I have presented in my district group also in WhatsApp. That was there. So these are the 2 things. This case is still open. It is across the board consensus. Everybody doesn't want to buy this. Only ankylostoma duodenal causing such a thing, causing recurrent iron deficiency. It may cause theoretically, but how many cases are we seeing? Are we really aware of it, seeing so many cases? So I think we have to still keep open the mind and follow up this child. And sometimes possibilities that we may have a different diagnosis.
Absolutely.
Over to you, Mahesh, and then back to Deepa.
Yes, sir.
2-3 points. I have not seen honestly a confirmed case of hookworm, but I believe it's after all an infection. I don't know whether it can last for 7 long years. Same patient. That's one thing. Second, this child certainly has got failure to thrive and stunting. So obviously the problem is continuously there over 7 years and not coming intermittently. That's what I believe. And when I talk about a continuous problem, obviously water pathology is all along there. His anemia is causing, but what kind of anemia? And Anasarca will respond only to oral iron. He's received 1 transfusion, and after that iron, and then every time his edema is vanished for next 2 years. His edema is vanished. He's asymptomatic for next 2 years. That's unusual to believe. Sideroblastic anemia, as all of us understand, won't respond to iron at all. That's not a pathology. So giving iron won't be treatment. I believe one more thing can be required apart from what you said. Even if it is TTG IgA negative, we have seen few cases wherein the diagnosis was proved by duodenal biopsy. So was a duodenal biopsy done in this case? That's one way. And second, I firmly believe we have not yet hit the final diagnosis in this case. It's definitely need to be followed for long duration. And I will strongly recommend duodenal biopsy, because otherwise the whole thing definitely fits into probable celiac disease. Started at 3 years, went on and on and on with the anasarca. And as we all know, anemia per se won't give rise to anasarca unless there is cardiac failure. This tenderness of liver and all those things was because of impending cardiac failure. Every time it comes to you, you transfuse and it just stabilize that. And edema is simply because of hypoalbuminemia. Mind you, 1.5 albumin is not normal with others. I don't know whether you can get that kind of albumin with hookworm also, but I think I have read and heard somewhere that it can be rescued. But that severe anemia with iron, I will definitely strongly further review my diagnosis towards celiac disease in this child and work hard on that. Maybe a duodenal biopsy will be justified in this case.
Biopsy reports are awaited. So once it comes, I'll get back to you.
Yeah. Amit bhai, for want of time, I'll ask only one question, which is, I think, in every audience mind. Do you think passing of worms will give the final diagnosis, or should we get ova and cyst in the stool? Because both times stool routine was normal. So mother giving history of passing worms, will it be sufficient enough to take it as the final diagnosis? Please tell me.
So that is one thing that we have to believe on what they say. And secondly, even the scopy is showing the worms. So I think we have to understand at least worms are there. Whether they are the causative or things for this condition that we have to still wait for the response.
Okay.
And
Thank you.
These parasitic infestations are mostly intestinal, small intestinal. Pinworms are large intestinal. Those are the history. Many times passing worm is pinworms, and rarely if a large stool, which is a ascariasis. So ankylostoma, diagnosed on history of passing stool is very rarity.
I think we should start with the next case. This was a very wonderful case, and I surely think that this needs to be worked up and followed up further. So I welcome the next speaker, is Dr. Dinesh Hinge. Neha, can you just share his CV? So Dr. Dinesh Hinge, he is a assistant professor at Department of Pediatrics, JNMC and DMHR Savangi, Wardha. And he has also worked as a clinical associate for 6 months in NHSRCC Children's Hospital, Mumbai. So now I welcome Dr. Dinesh Hinge to present his next case. And the next team that will be facing this challenge is Nashik and Malegaon, Dr. Prasanna Parashare, Dr. Piyush Ranbhur, and Dr. Jitendra Gandhi. So I hope the Nashik and the Malegaon team, they have joined.
Yes, ma'am, I'm there.
Yeah. Yes,
Okay.
ma'am.
So I request,
Yes,
so over
yes.
to you, Dr. Dinesh, you can start with your case.
Good evening, everyone. Hello.
Yes, sir, you can proceed.
Okay. My patient is 6-year male child born of non-consanguineous marriage and admitted with the chief complaints of distension of abdomen since 3 years and difficulty in breathing on and off since 1 year. So, which system you are thinking, please?
So abdominal distension is mostly will go for GI systems.
Yes.
Yes.
And breathing difficulty on and off, it could be because of abdominal distension, which is causing difficulty in breathing. That is first I will think of.
Okay, sir. Okay, sir. We'll see the HOPI for these chief complaints. The patient was apparently all right till 3 years of the life, and then he developed the generalized uniform abdominal distension, which was insidious in onset, gradually progressive over 2 to 3 weeks, and decreases by tapping only. But again, it increases after 3 to 4 months. It was not associated with pain in abdomen or any other complaints. This was happening around 6 to 7 times in over the 3 years. The patient also complained of the difficulty in breathing during the distension of abdomen, and that aggravated by the lying down, but he was comfortable when sitting up, and after the ascitic fluid was tapped. On inquiry, the patient also complained of, give the history of the fever, which was a low grade, intermittent, and 3 to 4 episodes every year, which was around lasting for the 5 to 6 days, and the treated symptomatically in the nearby local hospitals. So
3 years is a long history. Look like chronic illness first. Abdominal distension, that is ascites mostly, because it's getting relieved by tapping. So this is ascites. So it is clearly the difficulty in breathing was because of that ascites. He was lying down. It was causing difficulty in the lung expansion. Therefore, he was having that typical orthopnea like features. He was sitting and then feeling better because of that ascites. Fever, which was low-grade intermittent, I feel it could be because of infection. I will think of peritonitis, which can be secondary to the intervention that was being done, and then he was treated, therefore he was getting better. Now, why ascites is being there for last 3 years? So I will say that yes, the etiology, anatomy is, say, liver, I will consider. I will like to see for other signs of chronic liver disease. I will like to know about jaundice. I will like to know about any other features of chronic liver disease like any angiomas, palmarythemas, white nails, all those things. So any other thing for other team member, please.
Okay, sir.
Any history of like recurrent cough or anything like, history of like having difficulty breathing? So mild grade fever continuously for 3 to 4 years intermittently, having cough or any loss of weight history.
So this was the negative history, sir. There was no history of any cough, significant cough, or no history of any TB contacts or tuberculosis. or weight loss. The no history of the bleeding from any side like a melena or a hematemesis or hematochezia. There was no history of the jaundice also, and no history of the vomiting or diarrhea. There is no history of the decreased urine output or edema over feet or face. There was no history of the PND, paroxysmal nocturnal dyspnea, and there was no history of the joint pain, rash, and no history of the recurrent LRTI also. Would you like to more history?
Yeah, so it's only ascites.
So
Any history of
convergence, any history of convergence,
like any other space involved, like any pleural effusion that is
No,
being
sir.
no.
Sir, any history of convergence?
No, sir. No convergence, no altered sensorium, sir.
Any birth history?
Sir, we'll see the birth history. There was a normal birth history, sir. Full-term normal vaginal delivery, 3 kg weight, and no NICU stay. So, anything significant you want in the birth history?
Any history in mother that she got some whether she had received some injection like immunoglobulins or something, or she had history of hepatitis, that history of hepatitis B in her, whether this HbSAg positive in the ANC history.
No, sir. No, sir. ANC, PNC, and birth weight history was normal, sir. And the development of the child was normal as per the age, sir, and immunized as per the national immunization schedule. He received the last vaccination in 5th year also. And the past history was not significant that before the 3 years of the life. There was no history of the any medical history like a blood transfusion or any intervention or any surgical history. There was no significant family history. And the dietary history was suggestive of the deficit of the 250 calories, and the protein deficit was 3.5 grams. So would you like to ask apart from this history? Yes.
So looking at it, it doesn't look like to be a generalized edema. It is only localized to ascites.
Yes, sir.
The child is getting relieved and it is recurrent. The ascites is coming back recurrent. There is no history of bleeding from any side, so it is there is no history of chronic liver disease as such.
No, sir.
Any acute symptoms of pain in abdomen?
No, sir. No, sir. Would you like to?
There is no significant calorie and protein deficit as well. Development
yes,
in
expected to be normal.
Any history of hematemesis or anything?
No, sir. No history of any bleeding or hematemesis or melena.
Anything mother observed, like any distended veins on the abdomen when she was like giving bath or anything, whether some veins or dilated veins were visible over the abdomen?
Sir, we'll see that in examination, sir. But after ascites,
nothing like that.
In the treatment history, sir, during these 3 years,
there is no history.
Sorry. In the treatment history of during these 3 years, the child was hospitalized for multiple times, and that time the extensive diagnostic workup was done, and that was suggestive of normal. So basically CBC, LFT, liver function, renal function, chest X-ray, urine RM, CT, abdomen, and the 2D echo is also suggestive of normal. And that time, so multiple times therapeutic tapping was done and symptomatically treatment was given, and that child was also improved and again discharged, and again that similar episode was coming and going.
Considering all the scenario, there was no any like cardiac involvement. It is localized to abdomen, maybe without any liver involvement. Likely to be some means circulation like problems.
although CBC is currently normal, LFT is normal. So ascites, it's like I will still consider liver to be involved. There is, I don't think that logical thing or CCF causing ascites will come without any other complaint like dyspnea or generalized edema. Even nutritional also doesn't like it. It's going towards liver only.
Okay, sir.
Except,
We'll go towards the
moreover, it is
examination.
not going towards liver parenchyma. There is nothing which is showing towards parenchyma or it is any liver cell injury. There is no jaundice to say. There is no, in last 3 years, there is no hematomasis or anything which will say that it's there is evidence of portal hypertension as also. So I will still consider liver, but yeah, exact pathology that is difficult now. Okay.
So we'll see the examination of this child. On the general examination, the child was sitting comfortably on the bed. The temperature was 97 degree Fahrenheit, and the pulse rate was 130 per minute, regular in rhythm and normal in volumes. The peripheral pulses are well fed. Capillary refilling time was less than 3 seconds, and the respiratory rate was 30 per minute, regular, no subcostal or intercostal retractions. And the blood pressure was 94/60 mmHg on sitting position. And the saturation of the child was 98% on the room air, and the mild pallor was present, sir. And the no icterus, no cyanosis, no clubbing, no edema, and no significant lymphadenopathy. There was some jugular vein prominence was there as the child was 6 years, so you're not able to differentiate is what prominence or dilatation of the jugular veins. But there was some prominence is there. And though no signs of the hepatic failure also.
Okay, so there is no evidence that there is any synthetic function of liver that is getting affected. It is no generalized edema. Although jugular vein get prominent with ascites, it can be even something right from liver up to the right atrium we have to think of. So
these are obstructive
cause, but then again there is no signs of liver. There should be something. I will expect some liver like on USG at least we should get something on the liver, but it still is possible from liver up to right atrium, whether any block, thrombus or wave like in that we get in Burchiari that we have to think of.
Okay. So would you like to anything else apart from this examination part? And this was the anthropometry of the child. The child weight was the 15 kg with the ascites, and the expected was 19 kg and fall in the 3rd and 10th centile. And the height of the child was 105 centimeter with expected 111 centimeter fall on the 3rd and 10th centile. So
we can say it is acute because I will consider because of weight. It is slightly because of ascites. You might get the weight which is slightly on higher side. Height is not getting affected.
Okay, so we'll go for the system
calorie intake weight does seems a bit lower side, even if we consider it in ascites also.
Yeah, okay. That's right. That weight is affected, height is not yet affected. It's not much affected as weight. So something which, but the history is there in 3 years.
Yes, sir. Yes.
3 to 6 years. It is the time when I will expect. Okay, fine.
So on the systemic examination, sir, the abdominal examination on inspection, the gross generalized abdomen distension was present. The flank was full with an everted umbilicus. The skin over the abdomen was stretched with a prominent vein seen. The hernial orifices was normal. Multiple puncture mark scar was seen. And on palpation, the no guarding, no rigidity or no tenderness, no abdominal wall edema or scrotum, scrotum edema. Organ palpation cannot be done due to the tense ascites, but after tapping, there was no organomegaly. So on percussion, flute trill was also present. The auscultation vowel sound was normal. In cardiovascular system, the tachycardia was confirmed and the jugular vein prominent was there. So normal heart sound, no abnormal heart sounds or no murmur. And on respiratory wise, the child was normal, the air entry was virally equal and the clear, no adventitious sounds. And the CNS wise, the higher function was normal and no urodeficit was there.
Looking at abdominal examination, the infective cause is less likely. It may be due to pressure on the venous flow, maybe due to thrombosis or any other mass. The rest of the systems looks normal.
Yeah, so it's a gross ascites. So again, I'm going towards liver, but at this jugular
jugular vein
prominent.
and
I will still consider, yeah, it's something in the superior vena cava. I will consider some lesion. Then
so this is the history, summary of the history and the examination part. So these are the highlights of our case, like a recurrent chronic refractory ascites was relieved only by the tapping, and the breathlessness relieved by the tapping only, and the mild fever was there, and tachycardia and tachypnea was present. So pallor and jugular vein are also prominence, and the undernourished child little bit, and there was a gross ascites also. So what you think and what will be the provisional diagnosis?
yeah, I will still consider liver to be a prominent like anatomy. Fever, I will still think intermittent fever could be infective because of peritonitis. I will like to see that later whether it was because of peritonitis by looking at the fluid that was tapped. Other system involvement is not there. Complications apart from the weight, other system involvement is less likely. So I will still consider the lesion like from liver to, there is no liver is not getting affected, liver cell injury is not there, there is no any evidence of bleeding tendencies, there is no petechiae ecchymosis or any GI bleed. So I will still consider some obstruction over near the superior vena cava. That is one thing I will consider. Other cause of ascites it's like very difficult to say now, but I will still consider yes anatomy to be liver and obstructive. In something in the superior vena cava I will consider as the first thing.
Okay. So this was the DD, sir, the portal hypertension we are thinking, and the other was a chronic CCR and constrictive pericarditis. So in portal hypertension, which hypertension or any liver pathology will affect like this picture, sir?
Obstructive only something, but obstructive.
So it will be the hepatic or post-hepatic or pre-hepatic, sir? Or anything else apart from the liver?
Post-hepatic.
Okay. And what about the chronic CCF, sir? So you want to investigation for the child?
ECT abdomen was done, no? It was normal.
Yes, sir. Initially from the
With
outside.
all organs and all that.
Even chronic, any finding, like during auscultation, any finding the history of CCF, there was no evidence of any edema, pedal edema, or any signs of other signs of CCF which were there to say it's a.
No, there was no
Only-
sign of acute CCF, sir.
Okay.
So what about constrictive pericarditis in the CCF or cardiac?
The duration of illness is around
Around
years.
3 years, sir. Yes, the child
Echo
was 6
was-
years and 3 years was the sick child. So we'll go for the investigation, sir.
Echo was, I think, done.
Echo is normal, sir.
Yes, the previous
times,
echo was
which
normal,
not
sir,
showing anything, or I
on
think you have
the
not really-
previous hospital.
Yeah.
So what
Oral
else apart
hypertension
from this?
unlikely and presently in differential.
So any possibility of the autoimmune or Wilson or anything apart from this? Malignancy, like as causes of the ascites, rare causes of ascites. So we'll go for the investigation. So we did this basic investigation in our hospital. So most of the investigation, hemoglobin was the lower side, like a 9.4 and 9.5. The total count was, and other hematological investigation was normal. And the liver function is also normal, sir. The serum protein was 7.1 and bilirubin was also normal. And the most of the investigation was looking the normal, including the CPNAT of the fluid and the sputum, like just ESR was little bit higher side, sir, like 45, 42. So would you like to do another investigation for this child?
Please give me 1 minute. I was just I was logged out. I have just logged in again.
Sorry, sir.
Dr. Ramakant? Dr. Ramakant? Ramakant?
Yes, I am there.
Can you do one thing? Just disable the chat. During the case discussion is going on, please disable the chat because a lot of discussions happen there.
Yes,
And
yes.
then distraction as well as clues may be given.
Pallavi
So
madam,
during
if
the
you are
case
there,
discussion,
please
Chat disable करूंगा.
I will delete, sir. I will delete that immediately.
Yes.
Dr. Suhas, sir, don't try.
can disable it. People can register in between the sessions, please.
Dr. Suhas Kumar, Dr. Vasankar, sir, please don't write anything, sir.
Team, please go ahead.
Yeah.
Yes.
Chat has
Suhas
been
Kumar, sir,
disabled,
please
sir.
don't write anything.
Sir, chat has been disabled.
Thank you,
So
Pallavi
go
madam.
ahead,
Thank
sir.
you.
Yes,
Thank you.
yes, sir. Thank you.
Thank you.
Yes.
Proceed, Dinesh.
So we tapped the ascites fluid, sir. This was ascitic fluid report. Sir, it was a suggestive of the transitive fluid only. The SAG was the 1.4 and the culture was normal and the staining was normal, no showing any significant. And the LDH protein pH was normal. So on other investigation, like the ECG was suggestive of low voltage QRS complexes on the chest lead and the chest X-ray was normal. So lung parenchyma was normal and the cardiac shadow was normal and no any plethora or oligemia. And on tuberculin test, the 2 we use, that skin test was suggestive of 14 mm in duration.
Okay.
Okay. And the CBNet for the sputum and the ascitic fluid was normal. And after that, we did the sonography of the abdomen pelvis that suggestive of increased echo texture and irregularities suggestive of cirrhosis of the liver. And there was no evidence of any hepatic and portal vein thrombosis with gross ascites. And along with the Doppler study was normal. And for that, we did the CECT of abdomen that was suggestive of gross ascites only, but there is no other finding like a cirrhosis and all, but rest of the study was normal.
So low voltage QRS complex still is going towards like cardiac cause, and which is chronic CCF, yes, the liver can get affected. So that's
Okay.
why we can get this altered eco-texture of liver. Yeah.
So anything else you want apart from this investigations?
So what is the cause?
Would you like to see the chest X-ray of this child? This was the chest X-ray.
Yeah, please.
Would you like to repeat any investigation, or you want to do a different investigation from above list, or whatever they did?
2D echo repeat.
Okay. So for that, we did the 2D echo again review with the senior pediatric cardiologist, and we found that the septal bounce was present and restrictive filling pattern was seen with the thickened pericardium and trival MR with ejection fraction of the 50%. And after that, we did the cardiac MRI to confirm the 2D echo, because previous 2D echo was normal. So that cardiac MRI also suggested of diffuse enhancing pericardial thickening with the maximum thickness along with the lateral wall of the left ventricle with small size left and right ventricle and dilated right atrium, left atrium, superior vena cava and inferior vena cava. Septal bounce was seen, as well as the infective and inflammatory changes in myocardium as shown in these images. This is the first image is showing the dilated right atrium and left atrium and the thickened pericardium. This is also showing the tubular heart, and this was the diffuse enhancement of the myocardium pericardium. So any comment?
It's diagnostic only.
So we confirmed the diagnosis of the constrictive pericarditis. For that, we have taken the opinion of the cardiovascular surgeons, as a refractive ascites was there, and since the around 3 years. So we did the pericardiectomy for these patients, and the tissue was sent for histopathological examination of the and that's suggestive of the tubercular constrictive pericarditis on the histopathology only. That histopathological finding was like a scageting necrosis and granulomas was there like that. And after that, we started the anti-tuberculosis drug for 6 months and prednisolone. The child was significantly improved after 2 months. So this was the post-op X-ray during that hospital stay only. So this X-ray was suggestive of little bit cardiomegaly. Otherwise, lungs and other parenchyma is looking well. So after follow-up of every month for 6 months and the stop AKT, and there was no ascites after around 6 months and the breathlessness and no any other complaint. The child oral intake was improved and weight gain was present. So child is still following us. So child is absolutely fine.
Yeah, very nice case, sir.
Thank
it was
you.
because of tuberculosis. Yeah, thank you.
Yes.
Thank you, sir. That was a very wonderful case and very well analyzed by Team Nashik and Malegaon. Now, I would request our experts for their valuable inputs on this case. Dr. Suhas Prabhu, sir. Over to you,
I
sir.
think this was also another really very unusual, interesting case.
Dinesh, please stop sharing the screen.
Sure, sir.
I think definitely the team was on the right track, in the sense that they identified that very clearly it was a cardiovascular involvement of the circulation in the abdomen as well as in the chest. This was based on the fact that there was persistent ascites and the fact that the superior, the jugular venous pressure was elevated. So that was suggesting that there was some kind of a back pressure there. The odd part for me, and I did think initially whether it was a constrictive pericarditis, was the fact that the liver was not enlarged. That's
Absolutely.
very, very funny. I mean, I would have expected the liver to be enlarged, and there was no enlargement of the liver is odd. Of course, the early previous report saying that the basic biochemistry, the renal function test, liver function test was normal, was fitting in with the picture. What was odd was the fact that the 2D echo was normal. But I think that just goes to show that 2D echo, unlike a blood test or even an X-ray, is observer dependent. You really need a person. The same thing I see with sonographies. You can have a sonography or a 2D echo done by a bad clinician or a technician, and you can be completely misled. And you really have to rely on what that person says, which is quite different from an X-ray. I'm happy to see an X-ray and CTs because I can make my own interpretation. Here I have to rely on what that person has interpreted. So I think that was the thing that really misled, but I still cannot explain why there was no liver enlargement. It looked definitely that it was not liver involvement, because for 3 years without any liver function derangement or jaundice was very unusual. An extrahepatic portal hypertension would not have been seen without any liver spleen enlargement at all. So it sort of looked like a cardiovascular problem to me. The 2D echo and then being normal and the liver being not enlarged was the odd points. Thank you.
Thank you, sir. Now I requested Dr. N.K. Subramanian sir to share his views.
I won't repeat what my dear friend Dr. Suhas has told, but I would like to go for a couple of things which they missed in the history. They didn't ask history of any umbilical sepsis. That history was not asked by the contesting team. I think that's a valuable history. Often we forget to ask history of discharge or redness in umbilicus. And you know, after going through so many things later, we come back to that history. And bowel habits were not asked by the participants when it is an abdominal distension. It's very important because recurrent ascites was there. That's fine. I was fairly coming to the diagnosis of constrictive pericarditis. And whenever you get a case of distension of abdomen in absence of pedal edema, this is more likely to be constrictive pericarditis than otherwise. You know, that's something which my teachers of medicine have taught to me, not pediatrics, in my undergraduate days. And there's a syndrome called as Meeks syndrome, where there is polycirrhositis, and in that you can have pericardial effusion, pleural effusion, ascites also, but the pleural effusion may not be large. You know, it could be small, but then you know they don't present with this recurrent ascites or tense ascites, which was a classical feature of this. The biggest clue from this patient was a distended jugular vein, and that was the clue that should shift the causes post-hepatic. Was it Buddhishia or otherwise? I would also ask the history of sometimes this Ayurvedic medicine or proprietary medicine being given. I have attended being judged to one of the cases in AP, Andhra Pradesh Pedicons, when one of the students presented this alkaloid kind of ingestion, following which there was a secondary cardiomyopathy with the dilatation of all chambers of the heart, ascites as well as neck veins being distended. So there are chances that please ask that history, because these patients with distension of abdomen will not keep quiet with only our treatment. They are likely to take some other treatment, and that history could also be important from the point of view of liver cell injury. What I do not know, and it is my limitation because of my interest in respiratory, but the ultrasound was suggestive of cirrhosis. Will we get a cirrhosis secondary to constrictive pericarditis? I'm not sure. We should just get a congestive hepatomegaly. Can I have from the person who is dealing with the case, was there real cirrhosis or was it biased by one of the sonologists? He wants me like 2D code to be repeated by some other sonologist. Was there cirrhosis or no cirrhosis?
Sir, there was a CCT was normal, sir.
No. Is there cirrhosis or no cirrhosis on ultrasound?
No, sir, ultrasound was suggestive of cirrhosis, sir. But we did the CCT.
So if you say ultrasound is suggestive of cirrhosis, then will that No, sir. If you say cirrhosis is present, that will explain why the liver was not palpable in the constrictive pericarditis.
No, Dr. Subramaniam, I think the cirrhosis diagnosis by the ultrasonologist is based on what they're seeing as shadows. I think it is a misinterpretation. With a totally normal FFT
If you
and a
say it as a
normal
misinterpretation,
CCT, I don't think that holds any water.
Agreed. No, on the same lines, like the lessons from the 2D echo, we need to have a good sonologist report because somebody should not attempt a liver biopsy in this patient, without getting a repeat 2D echo. So therefore, that was my suggestion, non-invasive first before we can move to invasive things. For a while, I was deviated to thinking of congenital hepatic fibrosis, looking at the ultrasound. I was biased by the ultrasound abdomen report. Anyway, that can explain most of the findings, but however, it was clear-cut cardiovascular case. But what was surprising to me was that why sputum examination was not done. If you say tubercular constructive pericarditis, extrapulmonary, that doesn't prevent anybody from, taking a induced sputum examination, because you will never know. A chest X-ray will not rule out a pulmonary component as well. So therefore, my sincere suggestion, and on the chest X-ray, I don't know if there were nodes, because they showed me some chest X-ray, and if it is not showing any nodes, I will be very happy. So that these were few of the comments, and constrictive pericarditis was even opined by many people in the group chat. I think that was more straight. This case was more straightforward than the turbulent worms that we had in the past. Anyway, I'll congratulate the presenter as well as the persons who were discussing, but for the fact that they were more like practicing pediatricians asking questions than medical students who would ask every detailed small history, which we'll accept, fine, fair enough.
Yeah.
Okay, thank you, sir. I could see even Dr. Mohit is ready with his analysis. So Mohit sir, can you just share your views?
Thank you. I was itching to give that because I had some different way of looking at it. I was just looking at a case of 6 years old who is having same recurrent complaint over 3 years without any progression. I was wondering which are the cases. Are they infective, inflammatory, least likely? They will be always progressive. I'm looking at some mechanical problem, a recurring mechanical problem. I get something like I get anatomical defect in the lung and that gets recurrently infected. You give antibiotic, it stops and again to recur after a few months. Was it something like that? Second is could it be some malformation and a rare autoinflammatory disorder. Just putting into those categorizations. Then I was looking at recurrent ascites. Now, if I look at the pathology of ascites, it could be sinusoidal or post-sinusoidal portal hypertension. Pre-sinusoidal doesn't give rise to ascites. So extrahepatic portal fibrosis or portal venous obstruction, they won't give rise to ascites. So it's either sinusoidal or post-sinusoidal. And third is, of course, a peritoneum itself, which can give rise to ascites. Of which, as Prabhu sir said, if there is no hepatomegaly, I won't consider a sinusoidal or post-sinusoidal, at least in the pediatric age group. Adult with a cirrhosis will have a contracted liver. Pediatric patient with cirrhosis never have contracted because they don't have that much time to contract. So I was wondering whether I'm dealing with some primary peritoneal pathology, honestly, going by the information given by you. Another thing is post-sinusoidal, apart from hepatomegaly, I would have definitely expected some pedal edema at some point of time, which you objectively said there was no pedal edema. And then you came with a SAG. You didn't tell me the SAG actually. You told me only about the albumin. I wanted the plasma albumin also to. So that organomegaly, no organomegaly to me was a very significant finding against any post-sinusoidal, maybe Budd-Chiari, maybe constrictive pericarditis, maybe cardiac. I think that was a very strong point against all these things if I had to go by our understanding of physiology and pathology. So honestly, I didn't think it is a pericardial constriction based on the information provided to me because there are a lot of things against it. One, no liver. Second, no pedal edema at all. Third, 3 years recurrent ascites. Now, I'm baffled to say if it is active inflammation COX. Now, you gave anti-COX at this point of time, whether it was burnt out COX which was there, because which COX will remain without fever for 3 years? That's something unusual. And LFT was totally normal in spite of cirrhosis. As you said, cirrhosis was not there, but chronic Budd-Chiari or chronic congestion is known to give rise to cirrhosis. It is known. So acute Budd-Chiari won't give rise to acute constrictive or acute cardiac failure won't. But when it happens for years, 2, 3, 4 years, it does lead to cirrhosis. Here, your USG was showing cirrhosis, but I was not having LFT supporting that report. All along, there were no cardiac symptoms at all. No exertional dyspnea, no LVF findings, nothing. Liver was normal. So a lot of findings which were not really giving me a clue to the proper diagnosis. Dyspnea was only during ascites. When he used to feel dyspneic. Otherwise, he never was dyspneic. So no cardiac features at all. I think those are the points I just wanted to put. So honestly, though Subbu, my friend, said that it was there on second, third slide. So Subbu, tell me, honestly telling you, till the end, I could not guess the diagnosis. Let me be very honest, based on the findings provided to me. Yeah.
Mahesh, I'll show you. I have written it down also.
No,
so
I'm
that
sorry, I
won't
said that. I was just,
one,
I was
but,
just putting my 1 + 1, 2 theory. I understand medicine is not 1 + 1, but I had a lot of logics and I told you what logics I have to support.
But Mahesh, one quick comment in response to you is that breathlessness history often is not very reliable in children. You know, sometimes they say he's in between better, but may not be really better. It is little subjective symptom, I feel. So we cannot be going strictly by absence of breathlessness. I'm sorry, but I'm telling you, like, it is a very, very subjective. Yeah.
Mahesh, the other thing is it would depend on how active the child is. If the child has been ill for 3 years and is just lying down and sitting up all the time, you will not notice any dyspnea, because in this case, the dyspnea would have been on exertion. If the child is not exerting at all, you will not get that history.
Could be. I was wondering, sir, 3 years is too long a time. Somebody leads to ascites, so much of compression, but still not having any cardiac primary symptoms. As Subbu and you said, yes, it could be on exertion.
No.
But I mean, those are the points I was wondering whether they are really giving you a proper.
As you rightly said, this was burnt out disease.
Yeah.
This is burnt out disease.
So it was more of mechanical rather than
pericarditis rather than an active pericardial.
Absolutely.
Thank you, sir.
I have got one more 2-3 observation and queries here. That here it was hepatojugular reflux was not told, but that would have been again this thing, and liver span on sonography or on clinical examination.
7 centimeters.
So this again for this age definitely would have suggested, and as Mohesh has said, the cardiac cirrhosis is a known condition.
Yes.
Cardiac cirrhosis is known condition. That is definitely there. So definitely, and we have seen patients before very high aggressive antibiotics before 90s, when we are doing our PGs in residency, we have seen 2-3 patients of constrictive pericarditis with history going on for 5 years, 6 years, and they were diagnosed. And we have seen, Prabhu sir might be having more experience, but we have seen that constrictive pericarditis going on for 5 years, 6 years, and still they do not have any cardiac symptoms other than the exhaustion, fatigue, and simple breathlessness, which is again anybody's guess for that matter. So this is definitely a cardiac cirrhosis probably. And secondly, the liver enzymes in liver cirrhosis, unless until it is decompensated, we will not get any liver finding for that matter. And again, the cirrhosis and the sonologist, how it compares nodules, it is an individual this thing. So enzymes may be normal, your PT, EPTT will be normal, all LFTs may be normal till the end, till we get decompensation.
I agree with you.
There was one quick comment to Dr. The quick comment to Dr. Mahesh Moite's observation. Mahesh, I was taught by the professors of medicine in my time, Dr. Srinivasan. I would like to invite him for discussion. In constrictive pericarditis, you can get distension of abdomen in absence of pedal edema. This was taught as something like some sign. You know, if you get pedal edema, think of myocardial involvement. If you get ascites but not pedal edema, think of pericardial involvement. This was taught to us like mathematics in those days. Srinivasan sir, you were
I wanted to tell, I had 3 cases of constrictive pericarditis in children in the adolescent age. And of course, we have seen in medicine department many cases. But here, these children, they were presenting only with this thing, progressive mild ascites and otherwise no other symptoms. And the child, had only jugular. And whenever you find jugular venous pulsation, venous enlargement, and then you find ascites, we have to rule out possibility of constrictive pericarditis with or without fever or other symptoms of tuberculosis. but it's worthwhile doing a echo, proper echo, and then this thing. Of course, here the X-ray itself shows the thickening of the pericardium. Yeah, thank you so much for.
Professor, you are saying something.
No, I wanted to make the ultimate comment really that tuberculosis can really fool you in so many ways. It can present in so many different ways that you cannot really imagine. So Mahesh, I mean, yeah, tuberculosis can fool you anytime. And so see one example.
Yes.
Tuberculosis is one disease. When you think of it, it is not there. When you don't think of it, it is there.
Sir, probably here tuberculosis did not fool us. Tuberculosis happened 3 years ago and got healed of its own, leaving the pericardium affected and which is compressing the heart all along. So presently, it's not probably active tuberculosis. Tuberculosis happened 3 years ago and got better of its own. Because he never had a fever as a predominant symptom in last 3 years. He never had fever at all.
Yeah,
I mean just my
there
guess.
is a
I'm
history
sure.
of fever off and on, going on for 3 years.
Yeah, low grade,
not really
whatever is
significant.
said, never documented, never significant. I mean, what I'm saying is
But
this is
in the
not
history, they
straightforward.
told fever of
Wonderful
5
case
days
though.
duration. No, in the
Sorry?
history, Mohit, they said fever of 5 days duration. I've written it down.
Yeah, low grade,
Dinesh,
off and on, whatever he said. I
so whatever
understand. I
it is.
understand. But that's
Once
not
you have a
present
fever in a
income.
chronic disease, this is active disease only.
Mahesh, again, it is a EPTB. Had it been pulmonary TB, we would
Acceptable.
have expected a fever.
Sir, one more observation. Because these patients constrictive pericarditis 2D echocardiologist, the size is not more cardiomegaly.
Yeah, absolutely.
Most of the time, ejection fraction is good, and they do not see the end diastolic volume, and they many times get misled that whether there is a constriction is there or not. So many times because ejection fraction is good, myocardium contractility is good, size is good, but the end diastolic volumes are not good. And these are the things probably in hurry, cardiologist, if you're doing 2D echo, it could mislead and it could be missed.
So really speaking, you need a good person to do it.
No, I wanted to know from Dinesh, when you are working up, fine, I accept that 2D echo is a very fine investigation to do. Will there be any ECG changes?
So there was a low voltage QRS complex, sir. Otherwise, heart rate was little bit tachycardia. Otherwise, no findings, sir.
Unlike acute pericardial effusion and no
ECG
you will not
changes,
find
sir.
changes except low
Yeah.
voltage.
Yeah.
Okay. Was there low voltages?
Yes, sir. Low voltages was there, sir.
Okay, that was the clue, isn't it? So
Yes,
if
sir.
suppose if some echocardiography person misses it, the pediatrician should be able to pick up that sign because 2 of them cannot be abnormal, both ECG and echo. And they both cannot be normal. You know, so somewhere we should try to correlate ECG, chest X-ray, and the echo. Then we can ask for repeat echo. Maybe that could be the take home for all of us. See, when to repeat echo? When a cardiologist reports an echo as normal. Maybe a question in the minds of many viewers. Suppose if you find any discrepancy between chest X-ray, ECG, and the echo, apart from your clinical examination, maybe that is the time in which you would not repeat the ECG, but definitely repeat the echo.
Thank you, sir. That was a very good discussion on both the cases, and I'm very sure that all our audiences may have taken a very good take-home messages from both the cases. And there's a lot to. There are different views from different dignitaries. I thank all of the dignitaries to have such a good discussion.
Deepa, before you would conclude, you wanted, there is one question that is not answered by me. I am from respiratory background. You trash me as an expert both for the cases that do not have any respiratory symptoms except the description of breathlessness. Okay. No, this is in a lighter vein. And I was really pulled, and then was thinking, is there anything respiratory in both of them? No, that's fair enough. But you tested my other side of it. Therefore, my apologies for the audiences. If in the other systems, I have not done the expert part of it.
Subbu, I will respond to that in a minute. The concept is such that which case comes on which day to which faculty, presented by whom, no one knows till the session starts. The whole concept is like that. In fact, today I am so happy. The core concept is really fulfilled here. Idea is we had a wonderful discussion.
Yeah. That's what is interesting about it. That's why I didn't miss.
The main beauty of this session is that anonymity of the cases as well as
No, Dr.
Dr.
Mahesh,
Prabhu,
I think the very basic thing that goes out the message is no matter what specialization you take,
Absolutely.
you cannot forget being a general pediatrician.
Yes.
I don't like to
Absolutely.
say I'm a pediatric ID specialist. I am a
Yes.
general pediatrician with a little bit of interest in infectious disease. So I think
Perfect.
that should hold true for all of us, because as Mahesh said, any kind of patient can come to you. You can't say I'm this specialist, so I am not going to be able to look at the others.
absolutely. Right.
Thank you. Thank you, sir.
Okay, thank you all.
So
Thank
yes,
you. Thank you.
we need to
Wonderful.
wind up the session. So thank you all the presenters. There was an excellent presentation and very good cases. Thank you all the participant teams. You have analyzed it very well, and of course our experts and all the dignitaries who have participated and for such a wonderful inputs for this both the cases and all our audiences. I also thank our well-known Vice President, Dr. Yogesh Parikh sir, for accepting our invitation for as a guest of honor. And I request all the audiences, because they basically this platform is for all the talented pediatricians from all over the peripheries of Maharashtra to present or to participate in this session, because we are here to share and to spread the knowledge and to share all these interesting cases. So once again, a request to all the viewers, please participate in this session, and let's try to make it more interesting. So once again, thank you all of you for being a part of this session. Thank you so much.
Good night, all of you.
Good night.
Thank you. Thank you. Good night, sir. Thank you.
Thank you.
Madam,
very
recording
much.
stop करा.
Pallavi madam.
पल्लवी मॅम रेकॉर्डिंग स्टॉप कर. Yes.
छान झालं सर आजचं डिस्कशन.
Yes, एकदम छान. Srinivasan sir, thank you for your inputs.
Innocent sir, thank you.
एक्सलंट होत्या. अतिशय सुंदर केसेस होत्या.
Ideal cases for discussion. I'm so happy.
एकदम
This is the purpose.
एकदम
This is the purpose of the
Classic
ticket. You
cases.
discuss a raw case. याच्यासारखी मजा नाही.
Right.
Amazing.
Ramakant, are you happy at least today?
I'm extremely happy. Still, I have got small suggestion, Kulkarni sir. Still, we started at 9:22 first case.
अरे मी किती सांगतोय, आपण सगळं कट कर.
नाही, it cannot be cut, sir. Every dignitary has to be introduced properly. Every guest of honor. So let us start by 8:45. So our case will start at 9:05.
पाहिजे रे. सगळ्या फॉर्मॅलिटी 5 मिनिटात संपलं पाहिजे. 5
बरोबर आहे
मिनिटात
सर.
सुरुवातीचं.
पण आता you are 100% academician. You are 100% academician.